So we want to continue on from respiratory distress to respiratory failure and eventually arrest. So this is where you determine in respiratory distress, maybe I need to give them oxygen, but in respiratory failure, you want to go ahead and intervene and start positive pressure ventilation. So a kid that's breathing, or an infant that's breathing less than 20 times a minute, or a child that's breathing less than 10 times a minute, would be red flags as far as rates if they're not breathing adequately or enough. Maybe they're really limp or unresponsive, or their heart rate's slow. And you'll be surprised, the fastest way to speed up a kid's heart is to increase their ventilation. So if you ventilate them one breath every 3 seconds, they'll actually increase their heart rate. And then signs of shock would be those weak and or absent distal pulses. So that brachial, the radial, maybe the pedal pulse in the foot, those are very weak or absent because the body is shunting the blood to the core, the heart, lungs, brain, and kidneys, the trunk of the body where it's needed the most. So a kid that's in respiratory failure, they're on the verge of cardiopulmonary arrest. So we want to do everything we can to prevent that. We may support respirations with mouth-to-mouth or a mouth-to-mask or a bag mask, whatever it is at an appropriate rate. So on kids, we want to stay with that 3 to 5, one breath every 3 to 5 seconds. If it's available, make sure you have supplemental oxygen going with that bag mask ventilations. And especially in infants, that heart rate drops below 60. So remember, 60 is kind of a red flag either way. Respiratory rate over 60, heart rate less than 60. We want to go ahead and start chest compressions even if they have a pulse. We don't want to wait till it gets down to 0 to set something up, and make sure that we get prompt transport, whether it's by ground or by air. The most common cause of circulatory failure is respiratory failure. They stop breathing first, and then they go into cardiac arrest. So we want to look for things that show that they're headed in that direction. Maybe initially an increased heart rate, maybe later on a slower heart rate, cyanotic or pale skin, and then mental status changes. If the heart rate is more than 60 beats, then we want to just make sure that we have good ventilations going, see if we can increase it a little bit more, but we don't have to worry about doing CPR compressions at that point. Altered mental status. One of the main causes of altered mental status in kids is that their sugar is low. They don't have to be a diabetic. They just have to have expended more of their sugar reserves than what they've taken in. So this is pretty common for kids that are in shock to have low blood sugar. They may have been poisoned. They may be post-ictal from a post-seizure state. After the seizure is done, they could have an infection. So feel the skin. If it's hot, they're fighting something. Their body's trying to fight that infection, so that's probably what it is. Could have head trauma. And if the parents, don't know, maybe it's a sign that, the kid was abused and they just don't want to admit it. Low oxygen levels, so look at the skin. Make sure you do a nice patient assessment, that pediatric assessment triangle of their appearance, their work of breathing, and their circulatory status, just mainly looking at the skin. Pay attention to the patient's initial vital signs, because you're going to take more, those are called your baseline, you're going to take more vital signs and then compare, are they getting better, are they getting worse, or are they staying the same? You always want to involve the family, but keep them calm. A lot of times you have to kind of lay out the ground rules for the parents. If the kid's awake and you're asking the child, maybe they're 9 years old or something, able to answer for themselves, and you're asking the child a question and mom answers, and you ask a child a question and mom answers. So a good way to do it is, what a little girl's name is, little boy's name is. First, I'm going to talk to your mom and ask her some questions. And then when I'm done, I'm going to ask you some questions. And it's not so much for the child, it's for the mom to say, okay, this is the part where the child needs to answer. Unconscious patients that don't have trauma, we want to replace them in that recovery position. Left lateral recumbent, left side, if at all possible. So some common respiratory problems. Remember that infants breathe primarily through their noses, so just a few boogers in their nose can make it really difficult for them to breathe, and a lot of times they have to cry to breathe. But a child that has a history of asthma, what it is it's a spasm, it's inflammation of those airways that get smaller than what they need to be. So here's the weird thing. They can breathe in, but they're having trouble breathing out. It's air trapping, and it's usually caused by something. That's why we call it a reactive airway disease. Something sets it off. It could be dust. It could be the dander from pets. It could be stress. Sometimes it doesn't take a whole lot. But the telltale sign of asthma is they produce a wheezing sound, usually on exhalation, again, because of that air trapping. And they're panicked, they're not able to breathe, so they're usually sitting in a tripod position. They're sitting straight up. Sometimes they purse their lips because it helps relieve the lung of some of those internal pressures. If they have medication, we want to help them take their own medication and arrange for prompt transport. People die from asthma, so you don't want to mess around in the field with that. Croup is an infection of the upper airway, and here's usually what happens is, the kids playing around during their daytime, no problem, and at dinner they don't eat very much, and they go to bed early, and their parents are happy. It was like, oh, they went to bed early. We can watch a whole movie without, having to watch all the kid shows. And then about midnight, they wake up because they hear this seal bark cough coming from the kid's room, and they go in there, and the kid's kind of nasally, but they'll cough, but it sounds more like a seal bark. If they make that whooping noise, they cough really hard, cough, 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 and then they go, ooh, then that could be actual whooping cough, otherwise known as pertussis when they get their immunizations for it. So the pertussis or whooping cough is different from croup. But I will tell you this, it does happen even in South Texas, and especially in the wintertime, just due to climate change. Let me see what the next slide here says. One thing that's really cool is they just need cool, humidified air. So your book will say, turn on the hot water in the shower and close the bathroom door. Well, I'll tell you to save your hot water, all you need to do is run the shower, because they just need cool, moist air. They need humidified air. And if you ever notice, some parents, will panic and put their kid in the car and drive them to the hospital because they have croup. And by the time they get to the hospital, the kid's doing much better. Why? Well, they took them out in the cool, moist night air, and that's all they really needed. So croup can be kind of self-limiting, but it is still scary when the kids can't breathe. Luckily, around South Texas, it doesn't happen very often, but epiglottitis, and it's severe inflammation of the epiglottis. It actually always looked to me like a fortune cookie. It just closed off. So it's so inflamed and swollen that it blocks the airflow to the trachea. Usually happens in kids between the ages of 3 and 6, and they have such a severe sore throat and a high fever that they're sitting bolt upright and they're drooling. And you look at the kid and go, why are they drooling? Well, it hurts too much to swallow. It hurts too much to cough, so they don't do these things. And signs of epiglottitis. And that's really a life-threatening problem, because if that closes off, there's no airflow for them. So big thing here is not to put anything in the kid's mouth. Keep them as comfortable as possible. Do your blow-by O2. You don't want to put a mask on them and agitate them. Make sure it's humidified if you can, and arrange for prompt transport. Drowning is one of the conditions that we're going to talk about that's wholly preventable. And you'd be surprised, large bodies of water and rivers and everything, kids don't drown there typically. They'll drown in backyard swimming pools, the little inflatable kinds, or bathtubs, or even commodes. So, second most common cause of accidental death in kids less than the age of 5 in the United States. So, one thing to think about, if you see a drowning child and you're not trained to go get them, don't attempt to rescue unless you know what you're doing. So signs and symptoms of, and we usually call this a near drowning. A near drowning is any drowning in the first 24 hours. If they drown within that 24 hours, then we call that a drowning. So near drowning. Assess the ABCs. If they do start to have water come out of their mouth, make sure you drain them to the side just like you would when you suction. And start rescue breathing, and if needed, start chest compressions. Stabilize the neck if there's any chance that maybe they dove in and injured their neck. And some kids with cold water drownings, they actually do quite well. There's been kids that have fallen through ice, and the water's just above freezing, and they were underwater for 45 minutes, and when they were rescued and discharged from the hospital, they didn't have any deficits at all. So, but once you get them out of that cold environment, you definitely want to dry them off and start warming them up. So drowning can be, pretty tragic for the family. And one thing to think about when we talk about doing CPR, CPR is not that magical thing that you see on TV where everybody gets CPR and everybody lives. In fact, for adults, I think the nationwide statistics right now are still around 10 to 12%, which means out of every 100 patients that go into cardiac arrest outside the hospital, only 10 or 12 per every 100 will walk out of that hospital. The statistics for kids is much lower. It's still around about 0.3%, which means for every 1,000 kids that go into cardiac arrest, only 3 will walk out of the hospital. So the biggest thing when we talk about kids and near-death experiences is prevention. Properly restrained in a car. If they have a pool, putting a fence, putting a barrier around it, teaching the kids how to swim. Your firearms in the house, teaching kids to respect them, and then putting them up and locking them away, because kids are curious and they'll pull stuff like that out. So those preventable things, I think, play more of a role. Heat stroke is a problem with kids, so they do get hot. They're very active. You watch little kids and they're just moving. You're like, wow, I wish I had that much energy. So movement produces heat. So if they're outside running around playing in the heat, especially when it's very humid. So we talk about a heat index looking at not only the temperature, but how humid it is, because higher humidities keep people from sweating, and that sweat being evaporated to cool the body. It doesn't happen as much. But if you have a kid that's hot, you want to rapidly cool them to the point they start shivering. If they start shivering, then you know that they're actually producing more heat than what you're able to dissipate. So you cool them until they start to shiver. Fevers are common in kids, and again, it's not how high their temperature is, but how fast they got there that causes a seizure. But at any rate, when they do have a fever, we also want to cool those. So and people that have sick kids with a fever, you'll see them all bundled up and everything. We'll start peeling those layers off, because we want to make sure that heat can escape. And one of the best places it can escape is from the head. We can fan them. We can put some moist towels on them, and drop that temperature down pretty quick. If a kid has a seizure, we want to protect him from injury. Don't hold him down. Most seizures only last like 30 to 90 seconds, not very long. It seems like a long time because they're scary. That's why a lot of times when EMS is called for a seizure, you get on scene and the seizure's over. It already happened. They're post-seizure. Seizures can happen from high fever, or from maybe they have a history of epilepsy. They know that they have seizures. Most of the time they'll vary in intensity. We think of a seizure as a grand mal, or the total body involved, where the eyes will roll back, the teeth clench, and then the body shakes with that jerking movement. One thing to note when somebody is having a seizure is they're not breathing very well, and so they may be pale or often turn blue. If they have urine in the bladder or stool in the rectum, they tend to lose control, and they'll become incontinent to those. So move them to the floor, protect them from injury. If they're hitting the head on the floor, you may pad with maybe a towel rolled in half or so, but not a huge pillow. That pillow will flex that head forward and make it hard for them to breathe. Supplemental oxygen even while they're having the seizure, and then definitely post-seizure, monitoring how they're doing, vital signs, and supporting those ABCs. If you notice that they had a seizure and they have a fever, go ahead and start that cooling process. So kids will have bouts of vomiting and diarrhea from time to time. One thing to note is that they tend to lose a lot of body fluids from just nausea, vomiting, and diarrhea. And the bad thing is, if they're vomiting, it's not like you can have them drink water to replace that. They would have to have an IV from Advanced Life Support or in a hospital. So you can check skin turgor, just kind of pinching a place on the skin and see if it kind of tense in that area. Sign of dehydration. Some kids will get so dry that they're crying and they don't even make tears anymore. If an infant or a small child is still in diapers, that's a nice indication too. You can ask the parents, hey, it's 8 o'clock at night. How many wet diapers have you changed today? And if they say, wow, now that you said that, I haven't changed very many, telling you how dry that kid is. Abdominal pain can be a serious sign of something underlying in kids, like appendicitis, especially if they have right lower quadrant pain. Appendicitis is usually seen in young people. Associated signs, if they're nauseated, they really don't have any appetite, maybe they vomit, they may have constipation or diarrhea, one or the other. And one of the things about assessing the abdomen, we press in, we palpate, and we say, does it hurt here, does it hurt here? If they say they're hurting the right lower quadrant, you want to save that for last. Check the other quadrants, and then very carefully check that right lower quadrant. When an appendix is inflamed, think of it as a blown up balloon. And the bigger it is, the easier it is to pop. And when it pops, it shares intestinal contents, which is stool, into that peritoneum and causes a severe infection. So be real careful with palpating sites, especially in the right lower quadrant, if you suspect appendicitis. Poison can be by ingestion. It can be an ingested poison, means that something that they took by mouth. So again, small kids like to taste things. They put it in their mouth, oh, it's a Lego, or oh, it's whatever. So a lot of things go in there. Signs and symptoms, they may have some residue that tells you exactly what it is that they ingested. And you hear kids drinking bleach and vinegar and all this stuff. You're like, wow, who would do that? It doesn't taste good, but they tend to do this. So some associated signs and symptoms: nausea, vomiting, sometimes abdominal pain, or diarrhea, or even worse, it slows their respirations, causes seizures and unconsciousness. So things when you suspect a poison, you want to find out what they took, how much they took, when they took it, and any kind of associated signs and symptoms of that child. So what they took, how much they took, and when they took it is going to be really important information. And then gather up anything that you think. So if you have an empty pill bottle, look at it, see when it was filled, see how many pills were in there when it was filled, and if it's empty now, approximately how many that they took. You want to contact the local poison control center, and the number is 1-800-222-1222. These people that man these hotlines are very educated on this. They have electronic cross-references that they can give you a lot of information, because sometimes they're going to direct you to have maybe the child, assuming that they're awake, you wouldn't do it if they were unresponsive, drink water, or maybe milk, or maybe even activated charcoal. Charcoal works by causing the poison to bind to it, and then most of the time it has sorbitol, which is a bit of a sweetener. Not that it makes it more palatable to drink, but it makes it where it causes a bit of diarrhea, so they expel that substance from their body a little bit faster. And by all means, monitor their airway, breathing, circulation. Some poisons are absorbed. It can be as minor as poison ivy, poison oak, as long as they're not, severely allergic to it. Or it could be from chemicals. So we want to brush that off. We want to irrigate it as much as we can, about 20 minutes. And then look for signs of what we call systemic poisoning. So it's all throughout the body that shows that they had this problem. So protect yourself from exposure. Brush off any dry chemical, and then irrigate it, flush it for at least 20 minutes. Try to identify the poison, so when you call poison control, you'll know. Look at the child for any changes, mainly in respirations and pulse. If the kid does vomit, you probably want to save some of it, so maybe the hospital can test and see what it is. Something that's really tragic is SIDS, sudden infant death syndrome. Now, we've come a long way with this. When my kids were little, it made sense that you put them laying down on their bellies. In that way, in case they spit up during the night, they wouldn't choke on it. Well, we found out that increased their chances of SIDS. So now we put them back to sleep on their back. And this is a child that, went to sleep and was completely healthy. Parents went, wow, I haven't heard from them. They don't usually sleep through the night. And they wake up and they find the child dead. Usually between 3 weeks and 7 months of age, with I think the peak being about 4 months. Happens to more male babies than it does female babies, and usually in the winter months. And there's still no definitive what caused it, but some kids that are at risk will be put on apnea monitors. It's just a belt around the chest, and the alarm goes off whenever they don't breathe. So you have a big decision to make here if you should get a call and first respond to a SIDS call. So when you get there, the child's dead, they're not breathing, they have no pulse, and depending on how cold they are, depending on maybe some rigor mortis setting in, again, it usually sets in the jaw, you may decide not to start CPR. I always think this, what's the worst thing that can happen if you do CPR on a SIDS baby and you transport them? They die? Well, they'll die anyway if you don't do anything. So I think it helps the parents to see you do everything that you can to involve them in their care. A lot of times, I'll take them in the back of the ambulance and say, hold their hand, they can hear you, keep talking to them. And that it's not going to change the outcome, but I think it helps the parents more than anything else. So here it says if the child's still warm, begin CPR. If the child is dead, well, if they're dead, they're cold, they're stiff, and that's going to be really hard to just say, hey, turn to the parents and say, I'm sorry, they're dead. And some kids, when they die, they model, so those bruise-like blotches, that's fairly common. You have to call law enforcement either way, whether you transport or leave them there. And a lot of times they are going to do an autopsy to see if there was something that's preventable, maybe for the next child in that family. But follow your local protocols on this, and make sure that you talk with a professional counselor. You talk with your EMS director afterwards and say, I'm having a hard time with this. Don't try to tough it out on your own. These are tragic for everybody that's involved. In trauma, for children, trauma is the #1 killer of kids age 1 to 42, so even into adulthood. And you're going to treat that injured child pretty much the same as you would for an adult, except you have to remember that maybe the kid can't communicate the symptoms as well as an adult, and they may be shy, they may be clinging to their parents and not want to talk to you. So you have to kind of adapt to the child's needs. That rolled up towel or rolled up blanket up under their shoulders to put them in a neutral position on the backboard. Not everything fits kids that fits adults. So if you put them, if you want to immobilize them, maybe put them in that short vest style splint, the KED, and you put a pillow on top of their chest and then buckle them in, and that immobilizes them really nice. So kids tend to compensate longer than adults do. So they don't show signs of shock as early as the others. We talk about child abuse and patterns of injury. I'm sorry, not child abuse, not there yet. Patterns of injury, types of trauma that they experience may be related to factors such as activity that may cause that injury and then the child's anatomy. So motor vehicle crashes, they tend to have more head and neck trauma. Whether they're restrained or unrestrained. Even if they're restrained, they tend to have head and neck trauma, but by all means, the best place to be in a car wreck is inside the vehicle, not ejected from it with that risk of the vehicle rolling over on them. So restrained patients, even so, may suffer head, spinal, and abdominal injuries from the seat belts, especially if they're not properly placed. Most cars now have the shoulder straps and the lap belts. If it's an older kind of car where they have the center seat in the back only has the lap belt. A friend told me this one time, and it makes it really hard to put a kid there. And they said, put the child you love. You have 3 kids, and they're going to ride in the car, and the middle seat does not have a shoulder strap. She would say, put the child you love the least in that lap belt, because the lap belt causes a lot of abdominal injuries that you won't have with that shoulder strap. Kind of hard to put a kid in there now after hearing that, huh? Bicycle accidents, again, head, spinal. So wearing helmets can greatly reduce the severity of that trauma from a bike wreck. Kids hit by cars, depending on the size of the kid, they usually hit pretty much at the chest, and then they fall back, hit their head on the road. If they're taller, they may go up and over the car. If they're smaller than the kid in this picture, they may go under. Falls from a height for an adult. Critical fall is 3 times their height. They're 15 feet. And for a child, it's only twice their height. So if a kid's 3 feet tall and they fall from something that's 6, 7 feet tall, that's more than twice their height. So that would be a critical fall for a child. Anytime somebody falls, there's 3 pieces of information you have to gather that nobody's going to know except for you at the scene. Number 1 was, what was the height that they fell from? What body part hit the ground first? And then what was the surface that they hit? Because if they fall out a 2nd-story window onto real soft St. Augustine grass, maybe hadn't been mowed for a while, it's nice and thick, and they land maybe on their side, they absorb a lot of that energy with their whole body, they're going to fare much better than a kid that falls out of a 2nd-story window on concrete and lands on their head. So 3 pieces of information that you want to relay that you're going to get to see that nobody else does. Burns also are a major cause of injury to kids. They play with matches. They, may be involved in a house that catches on fire. And smoke inhalation is the biggest part of this. So burns for kids, you'll treat much the same as burns in the adult. Treatment for trauma in kids. Stop the bleeding, take care of the ABCs, do a full body assessment, and get them packaged and going towards the hospital. Kids often show shock symptoms much slower than adults do, but they progress very fast, which means they're going to stay stable for a longer period of time, and then all of a sudden you're doing CPR going, what happened? They were fine a minute ago. So they decompensate very fast. So we want to be paying attention to those subtle signs and symptoms. The little bit of cyanosis around the lips, the cool, clammy skin, the rapid, weak pulse, the difficulty breathing. We want to pay attention to that because they're telling you I'm in trouble. We've talked before about seizures, and they may have seizures from a head injury, so even trauma can cause that. The greatest dangers, though, in trauma with kids is airway obstruction and hemorrhage. They don't own very much blood. I mean, a 3-year-old may only have a couple of liters of blood. So if you look and go, yeah, it looks like they lost about 500 milliliters. Like if you spilled a can of soda, and that's about how much fluid is around them, you're like, oh, that doesn't look like too much. Well, that's 1/4 of their blood volume. So it kind of is a big deal. Treatment is taking care of the airway, making sure you stop the bleeding, and getting them transported. Kids in car seats, if you find a kid that's in a properly restrained car seat, leave the kid in the seat until the ambulance arrives, and sometimes they'll transport them like that, and secure them in that car seat. Just roll up some towels on either side, tape their head down. You can see this little girl's not very happy about being the model for this car seat. One thing I will tell you about the car seat that she's in, it's good. It's above the level of her head. But that chest plate needs to be at just above the nipple line at about the armpit level. So that's actually a little bit low. And those straps are very loose. You want the straps to be nice and tight. Child abuse is a problem. Not only physical abuse, but emotional, sexual abuse, and then again, neglect. So you want to treat the child's injuries, but if you suspect abuse, you got to be an advocate for the child. So you look for things like multiple fractures that don't make sense. The parent says, oh, she was standing on the back of the kitchen chair. You're like, wow, that's quite the acrobat. How do you do that? Old bruises with new bruises on top of those bruises. So An early bruise is red, and then it turns purple, and then kind of yellow-green, and it's healing. Human bites, burns, especially like cigarette burns or scalding burns, and just bizarre things. They just don't make sense. Here's some examples of some bruises and old bruises, some bite marks to the knuckle, and then a scalding injury, like a child that was forced into a tub, and they, maybe, and they call it a sock burn, like where you would wear your socks. The feet and ankles are burned, the buttocks, and then the hands, where they're forcing a child into really hot water. Signs of abuse. So transport the child, get them out of that environment. And some in law enforcement, you get to the hospital, tell them, here's what we saw, document very well, If you don't transport, the parents say, no, I just wanted you to check them. Check them out. If you can, contact law enforcement while you're there. But by all means, contact them, if they dismiss you, contact them right away. Abuse can also be neglect. So just lack of adult supervision. We've gone to a call for a 3-year-old that fell off the top bunk bed and broke their arm. The 8-year-old was babysitting, and there was also a toddler running around in the little walker thing. Grandma was at the bingo hall, so we had to call the police to go get Grandma, because the 3-year-old broke their arm. Malnourished, unsafe living environment, or some kind of chronic disease that's not treated. In addition to other kinds of assault, a child that may have been sexually assaulted is going to be really withdrawn. And if you suspect this, again, contact law enforcement right away. Try not to contaminate the crime scene much, so only treat the injuries that you have to treat. And these can be very upsetting. It takes all kinds of people to abuse a child, but I think this is kind of the ultimate of people that they normally would trust, and these people are usually known to them. Could be a father, an uncle, or a grandfather, or the mom's boyfriend, or an older brother. A lot of times it's known to them, and you have to be the advocate for the child in this case. So you're debriefing calls that involve children. It makes you angry. How could somebody let this happen? Maybe it's an end-of-life issue for the child that's maybe only 3 years old, or maybe it's something that's going to be debilitating for them. So don't be afraid to speak up and say, I'm really having a hard time with this. Kids are going to tug at your heartstrings. These are going to be your hardest calls. And for me, being in EMS long enough to have raised my kids through it, it tends to be whatever age your kids are. You tend to kind of internalize, when your daughter's 10 and the victim is 10, you're like, oh, the same age as my daughter. So those are real feelings. So make sure that you come up with some coping strategies that will help with this. So just kind of in summary, think about the anatomy being different. They're not just small adults. Your approach needs to be different. You need to gain their trust. And if there's 2 of you responding, they tend to gravitate to one or the other, and let that person step in and be their buddy through all of this. A good thing to see is a child who's afraid of you. That's fun. That's great. A crying child. Best sound in the world is a crying kid. That means their airway's open. So if they're unresponsive and just really not with it, then we're actually really concerned about that kid being in a more serious state. The pediatric assessment triangle really works. The appearance, how do they look? Sick, not sick. The work of breathing, are they really having a struggle to breathe, or are they going to tire out from that? And then what does their skin look like? 2 biggest things that you want to do is maintain that airway and stop the bleeding, should they be bleeding. Look for things in their mouth. Anticipate a child that was healthy 1 minute and now can't breathe, has an obstructed airway, so follow the steps to relieve those. Respiratory problems, we talked about asthma and croup, and those are pretty common. Usually patients will have their own medication for that. And then other medical emergencies like drowning, heat-related problems, seizures, dehydration. We've covered all of those. Poisons, remember that number, poison control, 1-800-222-1222. And wealth of information that you'll get from them. SIDS is real, and it happens, and it is very tragic. Remember that trauma is the leading cause of injury and death in kids. So we do a little bit of a review. The purpose of the Pediatric Assessment Triangle, the PAT, is to guide the hands-on physical assessments. Not really. Help you to determine if the child's vital signs are appropriate. It doesn't have anything to do with vital signs. Allow you to quickly form a general impression of the child. Yeah, so you look at them and you're able to kind of gauge from those three pieces of information if they're sick or not sick. D says help you remember the systematic assessment process, and C is going to be the best answer there. Which of the following statements about SID, sudden infant death syndrome, is false? False. So you're looking for the one that's not true in here. It usually occurs in children between the ages of 3 and 7. No, not 3 and 7 years, but maybe 3 and 7 months. Very young, so not years. That would be false. No adequate scientific explanation exists. That's true. Occurs apparently in apparently healthy children. True. You should start CPR if the child is still warm. True. So the one that's false there is going to be 3 to 7 years. Should be 3 to 7 months. Which of the following is not common respiratory condition in children? So again, looking for the one that's not. Asthma, yes. Epiglottitis, yes. Pneumonia, not very common in kids, more so the older adults. And then croup, yes. So pneumonia would be the incorrect or the correct answer there. And this wraps it up for our pediatric emergencies. And we'll move on to our geriatrics.